No, that's Matthew McConaughey from Beach Bum. Yeah, it's not a very popular movie. It's actually a terrible movie. Just a great concept movie. Beach Bum. It's an icebreaker. It's an icebreaker. There you go.
Sorry,
You don't have to. I mean, the first two slides are me introducing myself. So, hey, it's going good. How are you? I keep being so close to finishing the paper, and then whatever. So now I have to do the disparity paper because it's due Sunday. So I'm working on it now. I'm going to turn it in on Friday. So push the police paper again.
Okay, are we all ready to go?
I'm ready. Yeah, she had it all set up. Yeah,
okay,
we're on
super.
Zoom.
All right, so we're gonna get going. Thank you all for being here. I want to thank the ERC for sponsoring the lunches that we have every week, because I just think it has really brought us all joy and also brought us all together. So thank you guys for making that happen. Vidisha, you know, it's not easy to figure out how to feed everybody once a week. So thank you to the ERC for doing that. And without further ado, I'm going to introduce Dr. Lee Friedman, who I think will tell us a little bit about himself. So thank you. Go for it.
Okay, so anyways, my name's Lee Friedman. Let's see if this works here. Good. Okay. So I'm an occupational injury epidemiologist, or an injury epidemiologist, and I do kind of two buckets of work primarily. I do a lot of things, ancillary things. So I'm just giving a little introduction to myself before we get into kind of the topic of the day. So one bucket is occupational health research. The other is general injury research or community injury research. So in the bucket of occupational injury research, I lead the Illinois Occupational Surveillance Program. It's a program now, we're going on year 15 of the program. It's a CDC NIOSH funded program. And in that, we have this fundamental program that we do general occupational surveillance. We also do a lot of original research in occupational health. We've published probably over 30 papers over the past 15 years related to this program. A lot of my colleagues in the room have been involved in these papers, whether they've known it's IOSP or not. We all take mutual credit. And we also manage the state's adult blood lead registry, because there's mandatory medical surveillance of adults that might be exposed to lead in the workplace. And we manage really the whole thing now. We manage the EDI data that comes in from labs to the actual database to reporting back to NIOSH. We also do reporting back to the state Illinois Department of Public Health. And then we also do reporting to OSHA. So anybody that has used to be anyone with over 40 micrograms per deciliter of blood leads, we would report to OSHA. Directly now, the actual rule is 25 micrograms per deciliter. We report those cases directly to OSHA for enforcement activities. We actually have a lot of potentially exposed workers and communities to lead-related manufacturing processes, predominantly battery manufacturing. I'm working with Dr. Basalim on a project trying to link these two aspects of work-related potential exposures with community exposures, using childhood lead as kind of our parameter of community-level exposures, because in Illinois, you can't go to school, at least a public school, if you haven't been tested for lead. So we have kind of this little population of, sadly, children that potentially are exposed. So we're in development on that project. We're still waiting for IDPH to get around and agree to share the data, even though in principle, we're going to get that data. So that's the fundamental program. As part of that, we also have two expanded projects, or two separate grants that are under this program. So it's kind of like a center. We have 3 grants under this program. One of them is where we work with OSHA for OSHA enhancement. We help them improve enforcement activities as well as consultation activities. I'm not going to go into detail what that is. We also help evaluate both emerging hazards, high-risk industries in the industry, as well as helping them develop new emphasis programs so they can actually do targeted enforcement activities as well as consultation, added consultation programs. And we do evaluation of compliance with various laws under the OSH Act, which is one of them I'm going to talk about today, which is the record-keeping law. In addition, we have a pesticide-related illness program, which is the same thing as we basically have a federal surveillance program that we do here at the state level that we report to NIOSH, which is led by Dr. Force. and Dr. Garcia. But in addition, really the main activities of that program was really policy development, because pesticides is this weird, I'm sure it's been talked about previously, it's this weird little exposure group that kind of falls through all the cracks. It actually falls in EPA's domain. EPA doesn't care about workers' health, so it becomes a serious problem, and we need to, not that they don't care, but it's not really a priority of theirs. Everyone cares about everyone's health in public health, but it's not a key priority. And there's also the actual enforcement activities are really kind of spread around multiple organizations. So they're working on trying to coordinate that activities and try to create a more uniform approach to dealing with mass exposures or even serious exposures to pesticides. And they do a lot of outreach. So that's the IOSP program. In addition, I used to be the PI on one of the projects on the Great Lakes Center for Farm Worker Health and Wellbeing. Now Dr. Madigan is leading that project. She's the PI of the surveillance project. So we are developing a surveillance program to monitor both morbidity and mortality of agriculture-related injuries and illnesses or agricultural-related personnel, which includes owner-operators as well as farm workers, as well as people who live on farms. We have a paper that's coming out very, very soon on ag-related injuries involving Hispanic Latino farm workers. And we're currently doing a project right now evaluating crash risk factors associated with ag vehicles. So we have access to police crash data. We actually have access to a whole array of different data sources. And we're using that to evaluate risk factors involving ag-related vehicles. So we can then, as part of the Ag Center, begin outreach programs to help to try to maybe mitigate that hazard. In addition, I work with the Minor Center. I'm sure you guys have seen many presentations from the Minor Center. I'm the lonely injury guy in the Minor Center there, which are dominated by exposure people and pulmonary health people. So I really try to focus on injury-related outcomes with the work with the Minor Center. And we've published papers on overtime, risk factors associated with overtime-related work activities. We do know generally in the literature that the risk of injury increases about hour 6 into a shift. The problem is that in the mining industry, the average shift is actually 10 to 12 hours long, and they work usually 4 days a week. So most of the workers are already being exposed to these long hours. We know with fatigue and other risk factors that risk of injury occurs. And we do see in our analysis that the risk of injury occurs after 8 hours of work, plus the severity of those injuries increase, plus the incidents involving multiple injuries in a single incident, or we call multiple injury events, also increases with overtime work and a whole series of other factors I'm not going to go into. We've also published on early shift related injuries. We know that especially in the mining sector, when people are coming in and out of the mine, if it's underground or even on the surface, when they're being transported to the face of where they might be doing the mining, that there is a lot of specific risk factors associated with that. And we've published on that element. We've also done mine level risk factors, like what are kind of broad mine level characteristics, including kind of the culture of a company that are associated with risk of injury. And we're currently working on a project looking at the association between chronic pain among predominantly retired miners and use of opioids and opioid use disorder through a really kind of unique data set through this Rasmussen clinic in the Appalachia. And they're exclusively coal miners. Bob could probably correct me if I'm wrong, but I believe they're all coal miners, but they're predominantly retired coal miners. In addition, we've also published on financial conflicts of interest among B-readers. So B-readers are people that are hired either by the Department of Labor or by a miner or the mining company to read chest x-rays to determine the presence of lung disease. And in our study, and this is something that I've been doing for about 20 years in terms of bioethics research, we did find that physicians that are predominantly hired by the mining companies are more likely to, when they read the chest x-ray, to determine that there is no lung disease present, which probably shouldn't be too much of a surprise. We actually, when we compare it to like people we call neutral readers, which are those that are predominantly hired by the Department of Labor, which is the first chest x-ray read. Okay, so that's my occupational health research that I do. I also do a lot of general injury research. So I work with a partner of mine, Dr. Holloway Beth, and we have this law enforcement epidemiology project where we look predominantly at civilians injured during contact with law enforcement personnel. But because we're both occupational epidemiologists, we also look at occupational risk factors of law enforcement personnel. But because most of the funding and research focus historically in the United States has really focused on law enforcement personnel, we've made it a priority to focus on civilian injuries. We produce an annual report. Our annual reports should be coming out in about a week or two that summarizes civilian injuries in the US and Illinois and Chicago. We do a whole variety of other research. I'm working with Dr. Basalim and Dr. Holloway Beth on a paper right now. We're been on the cusp of finishing it for a very long time. Things always get in the way. But it should be done hopefully this week or next week and out for submission. And then we do a lot of outreach. We work with media and advocacy groups to provide information on kind of the magnitude and risk factors and injury outcomes when civilians have injurious outcomes following contact with law enforcement. And we have a website here that's hosted through the UIC server. In addition, I do research on homelessness and people who are experiencing homelessness. We have a contract that should be coming in every day, any day. I work with Dr. Madigan on this, and we have currently our contract is with the state of Illinois, both the governor's office and IDPH, to evaluate broadly the morbidity and mortality of people experiencing homelessness. But we have a lot of other research questions that we engage in. I've done a lot of work on temperature-related injuries, both in general temperature-related injuries, which are cold-related injuries, such as like hypothermia or frostbite, and heat-related injuries, and then extreme weather events, principally flooding and motor vehicle crashes and lightning strike injuries. I also have done a lot of research in bioethics. I've done a lot of research in substance use and opioid research. Again, Dr. Basalim and we have a bunch of papers coming out soon on related opioid epidemic in Illinois. I do work in elder mistreatment, predominantly physical abuse and neglect, road safety, toxicology. I work with Toxicon, the Poison Center, and so on. And I even do a little environmental epi occasionally as Dr. Buchanan. I do a lot of stuff. I'm a curious cat. I decided but today I'm gonna try to distill it to one very small project. So part of this IOSP program, like I mentioned, we have a project with OSHA where we are evaluating compliance with a new record keeping rule that was passed in 2014 that actually came into effect in September of 2015. We want to know, are employers actually complying with this new rule? So let me give you a little background. So in the United States, our surveillance and information about occupational injuries and illnesses is very, very decentralized. It comes from a whole array of different sources, potentially. We don't really have a very centralized data source. So I just want to keep that in mind. Nationally, our two kind of centralized or main data sources that we use is first the 300 log system, which is mandated under the OSHA Act. OSHA enforces it. And it's a passive record keeping system where certain employers, large employers and those in high risk industries, have to maintain a 300 log where they record any injury resulting in more than first aid, but it's passive. They don't have to submit it to anybody. They just maintain it, they store it. And then if OSHA comes in and does an inspection, then they'll ask to see that OSHA log. Now, the Bureau of Labor Statistics actually uses that system to then develop our national estimates of occupational injuries and illnesses for what we call the Survey of Occupational Injuries and Illnesses, the SOI survey. And that's where we get, when people say, oh, there were X number of million workers injured in a given year, that's the survey we use. And that is basically couched on top of these 300 law or record keeping rule that was mandated under the OSHA Act. In addition to that, we have a separate legal system for workers' compensation laws. While it's federally mandated that every state has to maintain workers' compensation in part or wholly for its workforce, Texas is an example where they've exempted a large portion of the workforce from being required of being covered by workers' compensation. But the problem is that every state actually sets different laws for workers' compensation and even what is reportable. While there is a national standard of what a FROI has to look like, which is managed by this organization called IABC. This is the beauty of being in something for too long. You learn about all these weird peripheral organizations. The fact is that what is considered reportable varies from state to state. So in Illinois, only injuries and illnesses that result in more than 3 days of lost work are technically reportable under this FROI system, whereas in some states, all cases that result in any medical claim must be reported, some only those that result in more than 1 day of lost work, and some even more than 14 days of lost work. So it's not a system that can be easily compared across states. So really, we end up relying on this SOI survey as our main national survey. Plus, there's a whole variety of laws at the state level that might require specific, illnesses, mechanisms, or causes of, or exposures that have to be reported. Michigan is probably the most advanced state where they actually have a mandatory reporting law of medical providers have to report work-related injuries to the centralized state system, which is run out of Michigan State University with Dr. Rosamund's group. Okay. And that's important because I'm going to be talking about their studies because them and us are the only two people actually doing this research right now. Okay, so let's now get to the actual research question. In 2014, OSHA passed this rule, and the 300 log system, remember, is a passive system. People just record it if they were mandated to report it, and they can just store it away. They wanted to create an active reporting system. So they, thought they were being practical and said, okay, let's only focus on the most serious injuries. So those include all fatalities, all hospitalizations, and then amputations and loss of eye. We want you to report those to us between 8 to 24 hours. Okay, and this covers those that are normally exempt from maintaining 300 logs. So again, small employers and those in low risk industries still have to maintain these, have to do this reporting of a serious injury. So if you work in a financial company that only has 8 employees, so you're exempt typically by being in a low risk industry and a small employer, if you slip and fall into a pencil and lose your eyeball, that has to be reported. You don't get any exemption under that, okay? Again, so the idea was, okay, we're taking this passive system, converting it to an active reporting system, but more fundamentally, right? So normally, right, everything just gets stored. We actually made this mistake one time where we actually asked the Illinois Workers' Compensation Commission to get all first reports of injury sent to us that they used to have only filing through paper form instead of an electronic submission form. And we filled up 2 whole rooms to the ceiling within a month, I think. Linda can remember that too. It was a nightmare. So you end up looking like this. But additionally, what happens is that under the OSHA Act, OSHA has a statute of limitations of 6 months. What that means is that if they hear about an injury, but if it occurred more than 6 months prior to when they found out to the date of injury, they can't actually initiate an inspection on that. So it's a very short window of response. So the faster, the quicker they can find out about an injury, it means they have more time to triage the referrals and then actually do an inspection. Because the problem is that OSHA has very, very few personnel. That's the main fundamental problem of OSHA. It's not that they don't have the ability, the skill, or the desire to actually make workplaces safer, is that they're highly underfunded relative to the actual scope and size of industry in the United States. So just as an example, in the state of Illinois, we have 5 area offices that are federally covered. And in Chicago North, Chicago South, which are the largest offices, there's 40 to 50 inspectors in those offices statewide, which includes also our state plan. So Illinois is a weird state where we're a hybrid plan where federal OSHA has authority of inspection enforcement of the private sector. Our state IDOL OSHA plan has responsibility over all public sector employees and the consultation program. So in total, there's only 90 inspectors. On an average year, we do about 2,700 inspections per year, despite the fact that we have over 370,000 establishments that are actually covered under the OSHA Act. Not all establishments actually fall under the OSHA Act, okay? And then each establishment might actually have multiple work sites, and maybe only one work site might actually be the one where all the hazards are and all the injuries are occurring. So that 370 is very, very small. So it becomes very, very difficult, given the scope of the number of inspectors, to inspect everything. So if they're getting a lot of referrals coming in, they need to prioritize real and kind of pressing emerging hazards. That's what goes to the top of the list when they do inspections, because they know they don't have the capacity to do all the inspections possible. Okay. So on top of that, we also know that employers do a pretty crappy job with reporting. So Sarah Woolner, who graduated from our PhD program here in the UIC, she now works in the state of Washington. She's done a couple really great studies evaluating the quality of employer record keeping under just the basic record keeping rules. And she showed that over 90% of employers do not comply with the OSHA record keeping rules. And this is in part or wholly. And the main thing is that she demonstrated, and this has been demonstrated in other research as well, but hers was the best design that we actually have in terms of research design, that there is systematic misclassification of the severity of injury, that severe injuries tend to be classified as minor injuries and minor injuries tend to be not reported, where you kind of counterintuitive. You'd think it's easier to not report the minor injuries. It's harder to hide the more serious injuries, but that's not the case. And I'll talk about why that happens in another slide. And they're more likely to misclassify days away from work, particularly they'll trim the number of days a worker might miss from work. In addition, a lot of research, not just wellness research, shows that this underreporting and misreporting is more likely to occur among small employers, as well as workforces that are non-unionized, as well as specific industries. Construction industry is probably the worst industry where we really see this gross, both misreporting, underreporting, and misclassification, but also retail, AFF, which is agriculture, forestry, and fishing, and accommodation and food services. So why does underreporting and misclassification occur? So it falls into three buckets. There's a lot of research and it's all kind of confirms you can drop these things into three buckets. One is there's intentional underreporting. And that is kind of the incentives for that intentional reporting is a fear of OSHA inspections. And it does happen. In OSHA, when they set up this new record keeping rule, they had an employer that reported an injury that initiated an inspection. They have never had a referral from that employer since, despite the fact that we actually know there's other injuries that are being claimed at that reporter's site, at that work site. So it does act prohibitively on reporting. Another thing is that employers are afraid of the impact on their hazard rating for their workers' compensation premiums. So they know if they report days away from work or a serious injury, that there's a higher probability that will affect their hazard rating and premium. In addition, employer safety competitions or incentives also suppress reporting. A lot of employee groups and units, as well as supervisors and managers, get bonuses and other types of financial benefits or parties or pizza or free food upstairs if they have if they have no safety violations in a window of time. So it does act to suppress it. Another thing is you have unintentional under-recording because of just a lack of knowledge of the system. And this, again, we principally see in these small employers. HR law is incredibly complicated, as both Ed and Monique, who do this for a living and are trained in it, know. There is so much reporting out there, both at the institutional level, at the state level, and at the federal level. Injury reporting is just one of the many different things you have to report. There's wage and hour, there's compliance with EEO, and all these things you have to do, as well as training, compliance, and all this stuff that you have to do. The problem is it gets confused, and if you're a small employer, what often happens is you don't have a qualified HR professional in the institution to actually know about the laws and regulations, so they don't do it. And often it might be the president or COO that's doing all of basically HR. So it falls to the crack. And another thing is just a low priority placed on safety, and that gets at work safety culture. So OSHA actually, after about 2 years, just now back specifically to this law, this 2014 law record keeping, they estimate that about 50% of these serious injuries are not being reported to them. 2 studies out of Michigan confirm this 50%. It's around 40 to 50% out of Michigan is saying are not, whether it's amputations or all broad general injuries, are not being reported to their state OSHA program or the federal OSHA. But the problem is that there's still no comprehensive study that has evaluated this. OIG's really made this kind of highlighted this as a priority for evaluation, and that is where we come in, because we live in a regular state that is a free open market for workers' comp insurance and regulation. We are not special like Michigan. So that's what we are trying to do here. And how did we do it? We started with a probabilistic data linkage of OSHA referrals, and we linked 5 years of data with hospital data. Now, OSHA, we have a data use agreement. They actually provided us their internal OSHA data set of referrals. For just quality control purposes, we actually compared it to the publicly accessible data set. So you can actually see all referrals for the United States that have been made by employers. They make it available on the OSHA website. It's hidden. It's kind of buried under layers and layers and layers of pages, but it is up there. So just for QC, we looked at it, there was like a 99% overlap between them. And we also got the inspection and citation data sets, which just provide us much more comprehensive information about the incident, as well as the investigation data sets. These are all separate data sets. And then we linked it to the hospital data. So our first pass, our main data set that we used was only cases that would actually meet the OSHA reportable requirement. So that is anyone that had a work compare, that's how we determined work relatedness. Then any of those cases that were admitted to the hospital, and then any amputation, even if they were treated in the ED, any loss of eye, if it was treated in the ED as well as all deaths in DOA. Now, a little caveat about hospital data. Hospital data is not great for evaluating deaths because anyone who dies on the scene, or the vast majority of people who die at the scene, are unlikely to be taken to a hospital to have their death certified. They're more likely to be taken to a coroner or medical examiner to have it certified. So you're not going to catch them in the hospital setting. We still wanted to look at it because we knew there was going to be deaths in the hospital setting. And we'll come to that in a few slides. Then we matched on 8 core sets of concept variables. It's really much more variables than 8. These are the variables you see here on the side here, and we used what we call a multi-pass linkage process. So it was 14 steps. You start with the most rigorous, rigid criteria where you know the false match rate will be the lowest, and then you start slowly fuzzing it up, where you use fuzzy matching criteria, or maybe omitting a variable that may have high missiness, or you know that might be inaccurate in one data set, and you slowly work your way down till you feel comfortable that maybe you're getting to that bridge where maybe your false match rate might be crazy high. Okay. So, oops, I skipped over one. So I just want to give an example of fuzzy matching. Fuzzy matching, all it means is that, let's say in one data set, you think that maybe age is inaccurate. So in the OSHA data set, it's very possible that the age that they list for an injured worker might not be accurate because they're just talking to some supervisor or someone and say, hey, what was John's age? And they'll say, oh, I think he's 45. So it's very possible it's off, right? So you could say, okay, in the hospital data where you have the date of birth, you know the age precisely, maybe we'll say any, give it plus or minus 1 year of age variability or plus or minus 5 years. That's like the concept of fuzzy matching. The problem is in our data set, really where it came up was only about 20% of the cases in the OSHA data file actually had the hospital name where the person was transported to identified. And it's possible that also that hospital identified is wrong because a lot of hospitals have the same damn name. They're, Saint something of what it's over and you'll have a thing, or Ascension. They won't give the actual Ascension what, right? So you won't know what is the hospital. So what we actually did is we know the address of where the injury occurred. We know the address of every single hospital in Illinois. And we actually calculated, we being me, this is a lonely project here. We all do the royal we, is that I calculated the distance from the injury location to every hospital in Illinois. Then using a snippet of this code here, just for the little code geeks out there, I ran an array and identified the 10 nearest hospitals to any given to that injury location. And then on top of that, I also identified the 10 nearest trauma units, because in the state of Illinois and all states in the United States have trauma systems. Illinois, just for a little historical trivia, it was the first trauma system in the United States. We're also the first poison center in the world, was out of Illinois, so yay injury. But the reason why this is important is that in trauma systems, the rule is that if a person meets certain injury criteria, really basically serious injuries or maybe vulnerabilities of the individual themselves, you should bypass the nearest hospital if they don't have a trauma unit and take them to a higher level of care, which means to a hospital that has a trauma unit. So in that case, you just want to make sure that maybe they bypassed all the near hospitals, which are the community hospitals. We do not have a some states have a trauma system where you have grades of 1 to 4. Illinois only certifies levels 1 and 2. We don't have a 3 and 4 system in Illinois, but a lot of community hospitals actually act as these trauma level 1, level 3s, and level 4s. And what they do is they stabilize and then transport forward. But we want to just take into account the possibility, again, royal we, of possible bypass. Now, because we have 20% of cases actually have this information, I can actually kind of pre-test and evaluate the accuracy of this approach. So the average transport distance of the cases where we actually knew was 15.7 miles, 90th percentile was 39 miles. And if you actually look at greater Chicago area where we have a super high concentration density of hospitals, and then it becomes very, very sparse once you move out of the greater Chicago, the average transportation distance is actually 5 miles. So this 10 nearest hospitals is pretty accurate. Okay. So the problem is with linkage is that there's an inherent inaccuracy to probabilistic linkage, right? Because we're kind of guessing, this person kind of matches on all this information with this person that it is in fact the same person. So both theory and empirical evidence demonstrates that you can reduce the false match rate if you kind of follow 4 or whatever basic conditions can reduce this false match rate. One is the rarity of an event. So the more rare an event it is, the probability that you're going to have a false match decreases dramatically. Great example, right? We all remember COVID, right? How hard it was to do contact tracing during the entire pandemic, but especially during the surges, right? When basically person A was in contact with person B, but that person B was in contact with 20 other people that were also infected, right? So it becomes very, very hard because it's no longer a rare event. Everyone was sick at the same time, or almost everybody was sick at the same time, unless you were magic. So the more rare event, like Legionnaire's disease, makes it a lot easier to identify that case and to make sure that that uniqueness of that case will match. Another thing is the more variables you use in the matching criteria makes sense. Then you have more things the person has to match on, which means you'll lower the false match rate. Also, the greater the probability distribution of a matching variable is, the lower the false match rate will be. So an example would be, let's say marital status. Typically, most data systems, you have 4 boxes a person can fall in. It'll be single, married, divorced, separated, or widowed, and then the unknown category, right? So that's generally what most data systems capture. Widowed is usually rare, so people can fall into 3 boxes. And depending on your population, it could be evenly distributed or skewed towards single, whatever it may be, right? So it's not an even probability of a third, but essentially you have very, very few limited options. So the probability that 2 people will have the same status is very, very high. However, if you have date of birth where you actually have day, month, and year, the probability of 2 people being the same is very, very diminished. Right? You might have a histogram distribution because it's a working population where most people are like 20 to 55 in this population. So you'll have kind of a histogram on certain ages of birth, but the probability that 2 people in your data set will have the exact same date of birth becomes seriously diminished. And then also the completeness and accuracy of the data that's put into both data systems. So why does it work with occupational injury? So in an average year in Illinois, we have about 200,000 to 300,000 injuries and illnesses that require some acute care. Okay, we don't know the precise number. It might actually be higher than this, but that's our general estimate that we have from the Survey of Occupational Injuries and Illnesses and other data sets that have looked at, try to assess the universe. So is that rare? It doesn't look like it's really rare, but the fact is we know the date of injury, the date of incident, and we know the hospital location. So if you actually divide that 300,000, 250, we'll do 250,000, it basically gives us theoretically basically 3.6 cases per day per hospital. And that means that your linkage frame that you're trying to find an individual in is only 4 people, 3 to 4 people. You're not trying to find a person in the haystack of 300,000 people. You're only trying to find them in 4 people. And in my system, it's over 10 hospitals. I'm only trying to find them in a pool of 30 or 40 people. That becomes substantially better probability that you're going to find the correct person. Okay, now in empirical evidence, if you just use the criteria for OSHA reporting, there was less than 1 case that met the OSHA reporting requirement per hospital per day. Whereas if you just had all work-related cases, your average hospital only served less than 2 people per day. With, again, it's not evenly distributed across all hospitals. Some hospitals have much more because they're known for occupational health services, or they live in an area where there's more manufacturing and other types of high-risk industries. So even in the hospital that has the most cases, only 5.5 cases per day. So again, that's all we're trying to find. And just so you guys know, this is exactly what the NSA does. This is what Apple does. This is what Google does. This is how they can track everybody without knowing your name and your social security number. They use aggregate information to create this composite characteristic of who you are. So the more you put up online, the more information they have. Ooh, I'm just kidding. Anyways. So let's get to the actual results. I don't work for MSA. So OSHA, there were 3,716 non-fatal cases reported to OSHA and 917 fatalities published over that year. The hospital data, we had 14,250 non-fatal cases. Again, this is the main focus. We really want to focus on, at least I do, on non-fatal cases. But because we had fatalities, I just was curious to see what was the linkage in them. Now, of the 545 fatalities, almost half of them died within 24 hours. So a large proportion of those, I know when we actually had our trauma registry data, where we actually had the time of admission and time of death, that the vast majority of those are cases that were dead on arrival or dead after failed resuscitation. So they're dying very, very quickly within the first hour of admission. Now, that becomes important because we know dead at the scene people are not being reported to, don't pass to the hospital. Okay, so just among the deaths, only 47 of the 545 deaths that were in the hospital data linked to OSHA. So I actually coded through all the OSHA records, and the vast majority of the deaths that are reported to OSHA are people that die at the scene. So I'm coding out, doing text analysis on the narratives, and the vast majority are dying at the scene. So that's what ends up getting reported to OSHA. If someone dies after the scene, employers don't know. That's probably really the main reason, and therefore they're not reporting that fatality. However, what's really interesting about this is that despite the fact that only that 91.4% were not reported to OSHA, so we're well below that 50% mark, that the vast majority of the cases that aren't being reported that are deaths are non-traumatic emergent events. So these are your predominantly cardiovascular and respiratory emergent events where then people die. The vast majority of those, or the plurality of them, are acute myocardial infarctions. Now, a lot of people go, well, why am I reporting AMIs to OSHA? If some Joe is sitting at his desk, he's not doing insurance activities and he has an AMI and he dies, why is that work related? Well, actually, in the new record keeping rule in this chapter B5, they actually specifically call out acute myocardial infarctions, and they say, report them all to us. We don't want you making that determination of work relatedness. We'll make the determination of work relatedness. You have to report every single one to us, okay? Yeah. So now among the non-fatal cases, in our first pass, remember my first pass of my data set that I actually have are only hospital cases that would technically meet the OSHA reportable criteria. Only 41% linked to the OSHA data, only 41% of the OSHA cases linked to the hospital data cases. So then what I did is I did multiple passes later where I expanded the frame of who I was linking to. And what I found was that 24% of the cases that were reported to OSHA actually linked to cases in the hospital data that had the correct injuries or serious injuries, but did not have a work comp payer. And this is, again, in light of what we know in the literature, is there's a lot of cost shifting that occurs when people get injured at work, that the private insurer ends up picking up that cost. And this provides us evidence of this. And the reason for that is that workers don't get a workers' compensation insurance card. They don't know about workers' compensation. Linda has done some work, Linda Forrest has done some work showing that when they actually ask workers what workers' compensation is, they have no clue what it is, the vast majority of them. And in addition to that, you actually have an incentive not to report. Workers are afraid to report work relatedness because they're afraid they're going to lose their jobs. So you have these things acting to then lead to this cost shifting to private insurances covering workers' compensation costs. In addition, 21% of the OSHA cases link to outpatient cases that are not reportable. So you break your arm, break your hip, break your back even. Sometimes you don't get admitted, as weird as it may sound. You could even have a penetrating injury, right? There's a lot of cases where people get shot, they're discharged, never get admitted to the hospital, right? Those cases actually should not be reported. And we've seen that for over 15 years in our research in Illinois, that certain employers will always over-report just because they'd rather err by over-reporting than under-reporting. So 21% were these over-reported cases. In addition, 8% were likely treated out of state in St. Louis and in Indiana hospitals. So we actually have these hospital transfer agreements, interstate hospital transfer agreements. So anyone really around East St. Louis, Fairview Heights, if you get a traumatic injury in that area, very high probability, especially if it's a serious injury or moderate injury, that you're going to be transferred over the bridge into St. Louis to two hospitals in St. Louis The same thing south of greater Chicago area, when you get down to around Kankakee, all those traumatic injuries, if you're not then treated in Urbana-Champaign, you're going to be treated in an Indiana hospital. And there's a couple in Iowa, there's one hospital in Iowa and some in Wisconsin as well, where you have these transfer agreements. We actually get data from those hospitals in our hospital data system, but only 27 of qualifying cases that would meet the OSHA reporting, if this 1,071 OSHA qualified reporting cases actually linked. So they just get lost. We know that the states don't do a great job if they're out of hospitals reporting the cases back in. And then 6% did not match. So we had a linkage of almost 94%. We're doing multiple passes again. Me is doing multiple passes. We just make sure and refine the process. And in the end, our linkage rate was between about 10 to 15%, well below both the OSHA estimate as well as what's happening in Michigan. But again, Michigan's a very unique state. So who is less likely to be reported? Female workers are far less likely to be reported. Older workers and people with comorbidities. Again, this is in line with people who have non-traumatic conditions or are coming in for AMIs, respiratory distress, whatever it may be. Those individuals are far less likely to be reported. Plus rural residents, particularly rural residents, white non-Hispanic rural residents are far less likely to be reported. The problem again with OSHA is OSHA's bandwidth for inspections really, they tend to concentrate around their offices just because, again, they have so few inspectors. Any work site that is really, really far away from an OSHA office, particularly in rural Illinois, tends to kind of fall into the zone where they're far less likely to be inspected. And therefore, there's a higher, they're not getting communications about record keeping and reporting, et cetera. And that's likely contributing to this pattern. So when we look at medical conditions that are less likely to be reported, what we see are that the illnesses that are non-traumatic injury cases are very, very few of them are actually being reported. So about 1.3% of almost 5,500 non-traumatic injury emergent cases are reported to OSHA. And again, these are your cardiovascular events, respiratory events, and other emergent events. Again, under the law, all of them should be reported. The employer should not be making that decision. Plus musculoskeletal conditions related to the spine, knee, and shoulders, such as like a ruptured disc, those are not being reported. DOA cases, amputations, only a third of amputations that were treated in the ED were reported to OSHA. And again, most amputations are actually treated in the ED. You rarely get admitted unless you have a severe amputation above the wrist or above the ankle. Plus, patients that are admitted but have shorter lengths of stay. So the longer you're in the hospital, the more likely you are to then be reported to OSHA. Plus injuries occurring on weekend. This makes sense given the fact that HR staff usually don't work weekends, where your manufacturing staff might actually be working 24/7. So then there's no one qualified to understand, wait a second, I think we're supposed to report that because it's a Saturday or Sunday injury. And then suicides as well. Okay, so next steps, I'm almost done. Next steps is we're working with OSHA to improve both through their consultation program or compliance assistance programs to improve knowledge about the record keeping rule. We're also working with OSHA and other stakeholders to we're working on individual hospitals to develop mandatory reporting of work-related injuries, but we're also, our long-term goal is to basically mirror what's done in Michigan and have a law in Illinois that would require all medical providers to report work-related injuries directly to OSHA. We do know that mandatory reporting laws aren't like a universal net capture, whether it's violence, elder mistreatment, child abuse. We know that a very large number of those cases never get reported by medical providers or mandated reporters, but it does improve reporting overall. So that's our hope. We would like to get closer to Michigan. Remember, our compliance rate is around 10 to 15%. We would like to get to Michigan, which has this mandatory reporting law, to get at least a 50%. It's still bad, but it's way better than 10 to 50%, 15% compliance. We also work with NIOSH and other state partners on trying through initiatives to get industry and occupation added to electronic medical records. We're also been advocating for the issuing of workers' compensation insurance cards to all employees, so that when an employee comes to the hospital, they would show their workers' compensation card, they would know how to then bill, it'd be easy. Employers are rabidly against this. But it would solve a lot of the cost shifting component. And then also mandating all workers' compensation claims be shared with regulatory agencies. So that's it. I have to leave in 7 minutes. Yeah.
I think I might have missed this, but was the only way that you captured work relatedness in the hospital data set, whether workers' compensation was the payer?
Correct.
So,
Yes. Well, no, that on first pass. For a second pass, I then went and I removed the payer information. We got another 24% linked without work comp payer.
right, but that was
Yeah.
with when you had OSHA having reported, right? So it's possible that there's like a missing group. that was not-
Yeah. Oh, yeah, absolutely. Absolutely. Like just broadly speaking in the hospital that work on, there's gonna, because that cost shifting, let's say it is 24%. That means we're missing 24% of all injuries, just generally every time we do an analysis using work comp payer. So there are either ICD-10 codes like Z codes that do payer, or where you're doing something activity for pay as a civilian or something like that. That captures a few more, but it's rarely used those codes. But that has been kind of institutionalized through this NIOSH work group where we're starting to use those as well. But yeah, we know we're missing. Payer is not accurate. Yeah.
And are the hospital systems interested in that? Are they interested in how much cost?
Depends on who you ask. Depends on who you ask, right? Workers' comp generally pays better than private insurance.
Right, so all those ones that are likely to be work related aren't captured in either data set and are.
Yeah, it's just, you need like a champion who's willing to spend their entire life and time on trying to advocate hospitals to ask that. You know, we can't get doctors. When I started public health in the mid-90s, I was learning about how we gotta train doctors that take a work history when they do a patient history. You know, that's 40, 20, 30, 40 years, whatever I am. I don't even know my age anymore. It still hasn't happened. It still has not happened. So I don't know. Yeah, a lot of money on the table, but someone's paying it, either the state or private insurance. Yeah. I'm sorry, I think Kristen, no? Oh, so
There was an effort to get industry recognition.
Yeah,
in the electronic health
it still
record.
is. It's still going. It's still going.
There's a canonized,
Yeah.
set of variables.
Yeah.
In the electronic health record. It just didn't get accepted because.
Yeah, but NIOSH is still pushing it. The CST work group is still pushing for that. It just each time there's an excuse why it can't be done. But all the like standards, like the requirements of compliance with standards have been gone through. So they've already passed it. So it's really just convincing people to adopt it as one of its core variables for EMR.
Yeah, thank you. Just out of curiosity, so you had mentioned earlier, I think there was